Welcome. We're glad to have you out on this wonderful fall night in Minnesota. The snow hasn't flown yet, and we're glad to have you here. And thank you so much for coming to the annual ICSI Reinertsen Lecture. This lecture has been named for James L. Reinertsen, who was the first board chair of ICSI. That's like 23 years ago or so. So the Reinertsen Lecture is an opportunity for us to bring a national expert or a local expert to talk on a timely topic, and this year is no exception. Earlier this year, many of you know, after many years of work to establish best practices for data collection of race, ethnicity, and language, that Minnesota Community Measurement published data on equity of care in 5 areas: colorectal cancer screening, pediatric and adult asthma, and diabetes and vascular care. The data was publicly reported by regions in Minnesota, but medical groups were able to obtain their individual data, accessing it by a data portal. Contrary to public opinion, we do not live in Lake Wobegon, after all. And Minnesota has some of the worst health disparities in the country. It's a major issue for us as a state who likes to say that we have the most excellent care of any place. But the data says, unfortunately, not for all. But true to Minnesotan form, we're taking the data to heart and we're saying, what can we do next? One of the things that we, and I mean the organizations that are here on the stage with me, Jennifer Lundblad from Stratus Health and Ann Snowden from Minnesota Community Measurement, one of the things that we have discussed together is how could we set a goal to involve the clinical leaders in clinical areas more in working on increasing equity. So although we have some thoughts about what a goal might be, we actually have said we want to engage the community more in thinking about how we would set that goal with measurement. We think it's really an opportunity to engage us even more in discussing what will it take to achieve health equity in our state for the populations that we serve. So I wanted Jennifer and Ann to kind of give you some of their perspective on this also as we think about working together with you.
Thanks, Annie. I want to echo the welcome to all of you and to ICSI for hosting the Reinertsen Lecture, which has just been a wonderful tradition over many years. So I think part of the reason we're all here tonight is that we know improving health equity is absolutely essential for us to be a healthy and resilient state, so that every person has the ability to have health and well-being and to achieve the highest and best in health and well-being. At Stratus Health, improving health equity has been a long-standing organizational priority for us. We have over many years designed and led improvement projects focused on areas and people and parts of the state where we have some of our greatest disparities. And we have an ongoing initiative to improve the cultural competence of health professionals and our health system. So we believe we have a lot to learn from each other. Again, I think it's the very reason we're here tonight and to learn from an expert as well, and that we can get further faster by working collaboratively. So I'm just so pleased to be joining, having Stratus Health be joining ICSI and Community Measurement in working together, in working with all of you in the audience, and working with those communities where those greatest disparities exist, so that we can better understand what the gaps are, and then most importantly, do something about it. So thank you.
So at Minnesota Community Measurement, we started on this journey back in 2008, that's about 7 years ago, to produce high-quality data that would be a foundational step in improving health equity in our state. And at that time, we developed the handbook on the collection of race, ethnicity, and language in medical groups to establish standardized data collection. Currently, we have 98% of clinics submitting these data. And we have over, the majority of those are following best practice. So these data are on race, Hispanic ethnicity, preferred language, and country of origin. We've seen this number grow over the years. And when we exceeded the 60% benchmark that most of those groups are following best practice, our measurement and reporting committee of our board said it was time to make this data public. So our first health equity of care report was published in January of this year, and we've seen tremendous support for understanding the data and for using it for quality improvement. We are really pleased to be joined by ICSI and Stratus Health and the people most affected by disparities to combine our collective wisdom and our efforts to focus on this very important topic. We will need your wisdom as well as we seek to raise the mean and decrease the gaps in these 5 measures and beyond.
So tonight, as we speak of working together on this important issue, we're also very pleased to have a national expert here to spur our thinking about what we can do to achieve health equity. I've been very fortunate to be able to be on the IOM's, so the Institute of Medicine's, roundtable on population health with Dr. Tom LaVeist, our Reinertsen Lecturer tonight. He's from Johns Hopkins School of Public Health, and his titles alone are impressive. He's the director of Hopkins Center for Health Disparities Solutions, the William C. and Nancy F. Reinertsen Professor in Health Policy. He has a myriad list of accomplishments, and it's long. Just some highlights. He was elected to the Institute of Medicine's National Academy of Sciences in 2013. He had the Article of the Year in the American Journal of Public Health in 2012. He was appointed as a fellow in Health Disparities Institute with the National Medical Association Health Institute in 2012. And in 2008, he received the Innovation Award from the National Institutes of Health. So now some late breaking news is after 25 years at Johns Hopkins, he decided it was time for a change. And he's accepted a new position as Chair of Health Policy and Health Management at George Washington University, starting later in 2016. So without further ado, please join me in welcoming Dr. LaVeist as ICSI's 2015 Reinertsen Lecturer on Achieving Health Equity by Design.
Thank you for that, and good evening. I feel so welcome here. This is so while you may not be Lake Wobegon, there certainly are aspects of Lake Wobegon that are true. There's some truth in every myth, and I'm sure that the welcoming spirit that I've encountered here is very much like what you would see or expect to find in Lake Wobegon. Make sure this is working. Okay, great. I like to be a moving target when I'm speaking, so just forgive me for not standing behind the lectern. We are in a transformative moment as a healthcare industry, of course, but the nation in general. And everything that happens within society ultimately finds its way into the treatment room. If you haven't seen it yet, just wait. Go to work tomorrow. It'll be there. Any social problem you can encounter will find its way into the treatment room. And this reminds me of another point, at least in my life, where we were as a nation in a transformative moment. This was back in the 1980s. I don't know if anyone here remembers the 80s, but I was there. I actually, it's not just some historical period. And at the time, I was a social worker in New York, and working with homelessness. And if you remember the 1980s, as I do, we had homelessness exploding all over the country. This SSI program had been changed, eligibility criteria was changed, and a lot of people became homeless as a result of that. We had this new drug called crack cocaine, which we didn't understand much about. We thought you take the drug one time and you're hooked for life, and then you have superhuman strength and all sorts of myths we thought at the time. And there was this new disease that we call GRID, gay-related immunodeficiency, right, which we now call HIV/AIDS. And so as a social worker working with homeless populations, obviously I was working with crack cocaine and HIV also, because that's the same population. Misery tends to travel together, at least in the social realm. And, they teach courses about New York City, social work in New York City in the 1980s in social work schools now. But as someone that was there, I didn't realize that we were in this important moment. I would get up, go to work. They would give me a list of people that needed to be housed. I'd spend the day trying to figure out how to get them shelter. If I got through the list, I had a good day. If I didn't get through the list, I didn't have a good day. But no matter what, the next day there was another list, right? And I feel like we're in a similar place. When you are in the midst of that, if you don't mind, I'd rather, if you could indulge me, I do like to move around when I talk. When you're in the midst of a moment like that, you don't have time to think about what are the bigger pictures, what are the drivers, what's causing this. You just have a list, you get up and you deal with the list and deal with what's in front of you. And I think that's where we are now. We are going through a transformative moment, a new American revolution. The society is changing dramatically. And I think this chart, nicely summarizes it. This chart shows the racial and ethnic diversity of the US population on the census for the second half of the 20th century. And it shows that the proportion of Americans that report on the census as being non-Hispanic white is dramatically reducing. And the Census Bureau projects that as we move into the 21st century, at some point in the middle of this century, we will become a nation that is a majority of what we currently refer to as racial and ethnic minorities. Now, this is probably not new to many of you in this room. But what I want to talk about is not just this pattern, but first I want to talk about what I think are the drivers. What is causing this? What's the big picture? Why is this happening? And then we'll talk about what this means for healthcare. This change in diversity is not just about race and ethnicity. It's not just race and ethnicity, but it's also language. Between 1990 and 2010, there's been an 80% increase in residents of the United States who do not speak English as a primary language. And if we look at where it's happening, it's not just in the states that we traditionally associate with diversity. It's not just New York and California. This is really a national phenomena, and it's happening here in Minnesota as well. So what are the drivers? What's happening? I believe that what's going on here is that societies evolve through stages of development. In demography, we have a model called the demographic transition model. And what that model says is that societies evolve through 4 stages of development. And these are the stages: pre-modern stage, early industrialization stage, urbanization stage, modern industrial stage, and post-industrial, which is where we are now, the United States. So what this means for health and health care is this. As we progress through these stages, it has implications for birth rates, death rates, and population size. In stage 1, we have high birth rates and we have high death rates. This is, agrarian farms, family farms. We have a lot of children because a very high death rate. Fewer children will live to be childbearing age. Also, if your economy is based on a family farm, having more children is an asset, right? You need more people to work the farm. As a father of 4 children, I can assure you that only works on the farm. Once you move into the city, they become liabilities. But anyway, as societies evolve economically, we start to urbanize. Death rates begin to decline because we have better food security, better sanitation, people start to live longer. The birth rate lags because culturally we're still attuned to having a lot of children, and it takes time for the culture to evolve. And as a result, the population begins to increase. Stage 3, the population really begins to increase because life expectancy now starts to increase. The death and birth rates begin to plummet, and then by stage 4, you have low birth rate, low death rates, and high population. So in the 1920s, when this model was created, it wasn't clear if there would be a stage 5, and if so, what would that stage be? And there was a lot of concern that population would explode out of control. USAID gets created in part to respond to what they perceive will be a crisis. There was fear that the planet wouldn't be able to sustain 9 billion people that was projected to be living on the planet by now. But instead of the population explosion that we expected, we got not quite an implosion, that's a little hyperbole, but this shows the fertility rates for every country in the European Union between 1970 and 2002. And as you can see, every country in the European Union now has a fertility rate that is below the replacement rate, meaning lower than, they're having fewer babies to replace deaths to maintain even population. This is the pattern for the United States as well, right? So what is stage 5? Stage 5, it turns out, is not a population that explodes out of control beyond our ability to feed everyone, but rather it's the stage that I call the stage of multiculturalism. What happens in stage 5, as we're experiencing here as well as in Europe, is that stage 4 countries, like the United States, attracts immigration from pre-stage 4 countries. The immigrant population will have a large proportion of the childbearing ages and will have a higher fertility rate. So this is what's happening. Now, when we talk about this in the national media, the narrative is always that this is about immigration and only immigration. So we have presidential candidates promising to build walls, a beautiful wall, with a moat and alligators and killer bees. And even if that wall were to be built, and even if that wall worked, and no one came in illegally across the border, we are still going to become a majority-minority population. Because immigration is part of the story, but it's not the whole part. It's not the whole story. So let's talk a little bit about that. So here's immigration. As you can see, there has been a dramatic increase in the number of people living in the country that are not born here. No doubt about that. From about 9 million in 1960 to about 40 million by 2010. So no question, immigration is part of the story. If we look at where people traditionally came from in the 1960s, it was mostly from Europe, but the actual immigration from Europe has actually been declining over that period of time. We look at immigration from Asia, it's been dramatically increasing. And when we look at Latin American immigration, it has been the largest driver in the country. If we put this into the demographic transition framework, it used to be that immigration primarily came from other stage 4 countries, but no more. Now it's pre-stage 4 countries. So immigration is part of the story, but that's not the entire story. Part of this is also about the force of population, of demography. This is the population pyramid for the United States for foreign-born and U.S. population. So the U.S.-born population has the traditional pyramid, large number of people at the youngest ages. As age increases, the proportion of people decreases, which creates a pyramid shape. When you look at foreign-born population, you see a diamond shape. Small number of children, but in the childbearing ages, you see much larger proportions of the population. Makes sense, right? Elderly people are less likely to immigrate. Children are less likely to immigrate unless they have parents with them. So it's going to be a childbearing age population. In addition to that, we also have this fertility pattern. Larger percentage, higher fertility rate, in addition to having a larger proportion of the population in the childbearing ages. So here, this is showing race and ethnicity. This is not just foreign and US born, because that data wasn't available. But what this shows is that you have a higher fertility rate for virtually every racial or ethnic minority group. If you look at the overall fertility rates for foreign-born versus US-born populations, you see that the women U.S.-born women are about 87% of the population. They produce about 79% of the children, of the babies. Foreign-born population, 13%, producing about 20%. So if you look at the rate of births per 1,000 women, it's 55 versus 93%. There's also another phenomenon, which is age at first birth. Again, we don't have that by foreign versus U.S. born, but we do have it by race and ethnicity. And again, earlier first birth. So that means you have a higher proportion of your population in the childbearing ages. You're having the first child at a younger age, and you have a greater proclivity to have more children. So that means more time in the childbearing ages to have more children. So the wall will not stop the inevitable transition into a majority-minority population. It may delay it, but it will not stop it. So what does this mean? Why is this important? Why is this important to a healthcare organization, audience? It's important, I think, for several reasons. There's a medical case or a healthcare case. There's also an ethical or social justice reason for why it matters. There's a regulatory aspect to this. And finally, there's a business case. There's an economic reason why we need to care about this, why we need to put resources into addressing the health inequities that we have in our society. So first, the medical case. So this is a chart from a study done by some guy named LaVeist a few years ago. And this is a study of 3 hospitals in the Baltimore area. And I guess I owe it to Johns Hopkins, my employer, at least my employer for the next 3 months. I owe it to Johns Hopkins to say that Johns Hopkins was not one of the hospitals in this study. Although if it were, I suspect the results would still look exactly like this. These are patients that came to these 3 hospitals, about 10,000 patients in this study, came to these hospitals with got a diagnosis that would suggest that they would be referred for cardiac catheterization. Right? Every patient on this chart was insured. They had insurance that would have paid for the care, the service. They were being seen at a hospital that had a cath lab. All right, so this is not about a healthcare access issue, because whatever barriers they had, they overcame those barriers and they got seen and they got a diagnosis. They had the ability to pay, they had the insurance. They were at a hospital that had the ability to provide the service. So you have a patient that is medically appropriate to receive it. The hospital would be reimbursed for providing the service and should be reimbursed for providing the service. But we see 2 things here. First of all, we have a general quality problem because the bar for the white patients is not 100% either. And that should be 100%. The bar for the African American patients, however, is less than 60%. So we have a disparity in quality problem. Now this speaks to the issue of whether or not simply improving access to care will deal with the health disparities problem. I was once talking to a member of Congress who, this member will remain nameless, but I'll just say this. This person has introduced a bill to create a single-payer system in the House of Representatives for 30 years straight. So I'll leave it to you to figure out who this person is. So he's from a nearby state also. And he's a great guy, but a little underinformed. So he's talking about his single-payer bill. And I asked him, well, what would that do for health disparities? And he looked at me as if I was completely crazy. What kind of an asinine question is that? It would eliminate health disparities, of course, because everyone would have access to health care and we wouldn't have disparities anymore. So, of course, we then spent the next hour with a little re-education about why that wouldn't work. But I think this speaks to that. This is another study that I think really speaks to it nicely. This is from the VA hospital in Pittsburgh. Now, these are VA patients. They're being seen at the same hospital, being cared for by the same set of physicians. And again, these are all patients that should have been referred for revascularization. And once again, we see Same problem. We have a quality problem because 100% of these patients should have been referred for revascularization, but only 50% of the white patients get referred. 100% of the black patients should have been referred, but only about 25, 26% of them got referred. So here we have two simulations of single payer, universal health care, with this, well, not single payer, but universal health care, universal access to care. We have patients that sought the care, so it's not that patients didn't want to get care. They showed up, they overcame their barriers, they got in, they actually got seen by someone and even got a diagnosis. And ultimately, we still find a disparity in the quality of care and likely a disparity in the outcomes. So the Institute of Medicine published this report. I'm sure everyone here is familiar with this report, Unequal Treatment. Right? Now, this report was not the first report done on health inequalities. In fact, it wasn't even the first report that the IOM had done on this topic. But this report has been massively successful at placing this issue on the front burner of the nation's health policy agenda. And I think that the reason that this report has been so successful where others have not been was that in 1985, Secretary of Health and Human Services Margaret Heckler issued a report titled the Secretary's Task Force on Black and Minority Health. Very uncreative title, however, very important report. This was 11 volumes of table and chart after table and chart demonstrating disparities in prevalence rates and mortality rates for every imaginable thing, right? And it showed huge disparities. But when the report came out, as was the case with other reports, even other reports from the IOM on this topic, people would look at the report and say, well, these are bigger societal issues, what we now refer to as social determinants. These are beyond the healthcare system. It's too big for us. These are things that are, we can't fix poverty. It's not our responsibility. What this report did that I thought was really clever was it narrowly focused on high-quality studies that had been done on patients that had access to care, that showed up to get the care, and focused only on quality of care received among this narrow group of patients that did not have access problems. And it showed overwhelmingly that we've got a huge problem in this nation in terms of different quality of care being offered to different patients who have similar ability to pay, similar resources, and similar access to care. So there's a medical reason, there's a healthcare quality reason that we need to be concerned about this issue of equity. The ethical case is the easiest thing, the easiest argument to make. We simply should address health equity because it's inconsistent with the values of the nation. It's not the society that we want to live in. Right? That cognitive dissonance demands that we do something about it. And probably most people in this room are convinced by the social justice argument. In and of itself, it simply is wrong. We should address it because it's wrong. But we got the idea, that is the center that I direct, the Center for Health Disparity Solutions, we got an idea of, is there another set of arguments or other arguments that we can create to maybe get more people to see the importance of this? Could we make a business case? Is there an economic argument for why this matters? And we did this report called The Economic Burden of Health Inequalities, where we calculated the cost to the US economy of maintaining disparities. We calculated that cost in 3 areas. One was in direct medical care costs. In other words, medical care services being used that otherwise would not have to be used if people weren't as sick as they are. Category 2 was lost productivity. So absenteeism, presenteeism, people taking time off to care for sick loved ones that otherwise they would not have to care for. And of course, mortality, premature mortality. So people are dying prematurely after, as a society, we invest in their human capital. So we provide schools, we train people, we provide social services, but then once we've invested in that human capital, people die prematurely before we can get a return on that investment. And we calculated that cost as $1.24 trillion over 3 years. Now, that's just a number. It's hard to wrap your brain around. What does $1.25 trillion mean? $1.25 trillion is about the size of the 11th largest economy in the world, which is India. Now, I can't tell you how much it will cost to fix health disparities. I don't know the number. But I do know that it costs a lot to maintain the disparities. And often when we seek resources to address the issue, the response we get is, well, it's costly. We don't have the resources. But I think it's important that we take account of the fact that it also costs to maintain a system that produces disparities. That's expensive also, and that's a cost that we should not continue to bear. Finally, another aspect of this economic burden, I'll tell you a story that was told to me by a friend of mine who is a litigation attorney. Yeah, I have friends that are lawyers. And he told me this story specifically because he wanted me to go out and speak to audiences like this and tell this story, because he's not able to disclose this. And this is a story about a hospital. He told me as much as he could without going outside of the confidentiality agreement that he's bound to. This is a story about a hospital. I just know it's a mid-sized city in the Midwest. I don't know exactly where. I don't suspect it's Minneapolis. And this is a story where a little girl is there for care. Now, this girl's parents moved to the country in the last few years. Her uncle has lived in the United States for about 5 years. But they don't speak English very well, neither the uncle or the parents. And they're meeting with the surgeon who's explaining the procedure and the risks. There's no interpreter, but he speaks a little Spanish, and the family speaks a little English. And everyone agrees that this surgeon is a truly caring person, widely respected in the community as someone who truly cares about his patients. There is no disagreement about that. There's no disagreement about the quality of this man's work. He's a very highly regarded surgeon who's had a long career of success, who genuinely cares about his patients. So there's no doubt that the 4 adults in that room truly cared about that little girl. Now, one of the risks of the surgery that he was to perform was that there could be kidney damage, permanent kidney damage. But they trusted him, and they signed the consent. And unfortunately, there was an adverse outcome, and she lost kidney function. Disappointed, the family went home and came back about a week or so later with my lawyer friend, who sued the hospital and the surgeon. The hospital quickly settled for $12 million. Now, $12 million is not an economic windfall for this family. $12 million is going to go to providing care for this little girl. So there's no happy ending here for anyone. Why did the hospital settle so quickly and so easily for that amount of money? Now, that was not a rhetorical question. That was an actual question. But I'll answer it for you. I won't make it. The reason that the hospital had to settle for this so quickly, for $12 million, is because while the parents did sign the consent form, there was no informed consent because they did not have an interpreter in the room. So the surgeon spoke Spanish. I mean, he could probably order dinner at Tijuana, right? And the parents spoke a little English, but not enough. Their 8th grade education that they got in Spanish was not enough to prepare them to translate and understand medical terminology in English. So here's the kicker, and this is the reason that this friend of mine wanted me to go out and put this in speeches and tell people about this, because he's not allowed to talk about it. No one involved is allowed to talk about it. These lawsuits are happening all over the country. And I don't know about your organization or whether you can sustain a $12 million lawsuit out of your general operating budget, because malpractice insurance does not pay out for civil rights violations, and this is considered a violation of the Civil Rights Act. So not only was the surgeon personally sued, but the hospital as well. So we're past the point of addressing health equity because it's the right thing to do, because it's a nice thing to do, because we should, because it feels good. We're past that. I don't even make that argument any longer. We need to address health equity because it is literally an existential threat to the survival of your organization if you do not manage this issue well. Have I scared anyone in the room? I'm trying to. Hopefully I'm scaring someone. You should be. This is a real issue. But it goes beyond just the economic. There's also the regulatory case. And I'll just quickly go through this. I'm not going to spend too much time on the regulatory stuff because I'm sure you guys are living through it. We're living through a regulatory avalanche right now. The accrediting bodies are all creating standards and elements and other regulations that require that we address this. This is the class standards, which comes from the Department of Health and Human Services. Can you just do this for me? By a show of hands, how many of you are familiar with the class standards? Okay, let me do it the other way. How many are not familiar with the class standards? Okay. Yeah, that's the number I wanted to get. Okay. So what I'll do is I will see to it that these slides are made available so that you can get these references, because if you don't know about the class standards and you are in a leadership position in the healthcare industry in 2015, this is not good. These are standards from the U.S. Department of Health and Human Services, 15 standards that cover 4 general areas. Some of these standards are actual laws, such as the story I just told you about. Others are regulations, and some of them are best practices. But it's important, I think, that every healthcare organization be aware of the class standards. Joint Commission has a set of standards and elements now in their hospital accrediting program. I won't go into the details there. NCQA. Now, this is from their one of their accrediting programs for health plans, but if you look at what they're doing with patient-centered medical homes and ACOs, they have similar standards and elements in those programs as well. So we're getting to the point where we simply have to do it. Now, how do we do it? What does this all mean? I think that finding common ground between patients, providers, healthcare administrators is really important. And how do we do that when the population is so diverse and the population of people that are serving the population is not diverse? We often think that there are bigger barriers between us than there really are. So I spent a lot of time in airports, travel all over the place. And one night I flew in late into Birmingham, Alabama. And I'm a Yankee, I'm a Northerner. So, I get sort of certain subliminal ideas about what happens in the South. I have this historical memory. I wasn't there in the 50s like I was in the 80s, but I know what happened, right? And so I'm walking down this dark, empty corridor in this airport. And with the way the human brain works, we see another person and we're deciding, okay, how do we interact with this person, right? Do I say hello? Do I not say hello? Do I make eye contact? Do I not make eye contact? That sort of thing. Or is it just me? Or don't we all do that, right? So there's a figure coming towards me in this corridor. We're the only 2 people around. And my brain is going through this. And we do it in a subconscious way, but we do it. And sometimes we are actually aware that we're doing it. And this time I was aware, okay, I'm deciding whether or not I should acknowledge a fellow human being who's the only human being around. And as this guy gets closer, I start to notice, okay, he's a white guy, looks like he's probably about my age, roughly, yeah. And I'm sizing this up. As we get closer, I notice that he and I are actually in the same cultural group. Now, how could it be that a black male and a white male would be in the same cultural group? Well, it's because as he gets closer to me, I notice that he's wearing a T-shirt that says Michigan football, I'm wearing a sweatshirt that says Michigan alumni. And we realized that we're both part of a cultural group that is extremely important to both of us. And we spend about 45 minutes talking about that football coach from West Virginia that has destroyed our program, right? And how much we hate this. And we bonded around our dislike for this, right? So, all right, now that's a funny story, but let me tell you another story. I spent a lot of time with healthcare executives, consulting and working on different things, right? And it's a story, this was a story from executive at Catholic Health East. It's a great story. I love to tell this because it's really a way of actually implementing a health equity frame, and for him it was instinctive. So he was telling me that he likes to walk around the hospital and just kind of look in and see what's going on. Right? And one day he's walking along the corridors of the hospital, and he sees a nurse go into a room. The nurse is a white female. The patient is an older black woman. The nurse is a younger white female, white woman. So he says, I'm going to hang around outside the door and eavesdrop on the conversation. And he does that. And she goes in the room, the nurse, and she does everything exactly the way she was trained to do it. She did everything right. She asked the right questions and everything. So he goes in the room. Oh, good morning, Mrs. Williams. How are you feeling today? Oh, I'm doing okay. You know, how'd you sleep last night? Oh, fine. Everything was fine. You hungry? You want to eat yet? Oh, no, I'm not yet. I'm good. Everything. And they ask her a few other questions, and then she leaves the room. Remember, the housekeeping staff comes in. Miss Williams, how are you doing today? Girl, my feet hurt, and I think they're swollen, and I just couldn't sleep last night. All that noise, all the beeping and all the noise, and, you know, I just had a terrible night. And they chit-chat for a while, and then the housekeeper leaves. So he goes over to her and says, well, what are you going to do with that? You just got what could be very important information. And she says, well, what would you suggest I do with it? Who's going to listen to me? And she's right? So that's one aspect of organizational culture right there. She's right. No one's going to listen to her. She is part of the care team, but is she, right? Next of all, he says, okay, how am I going to handle this situation? So he walks in, and he notices that she has a cross on the wall that the patient put up. And he says to the woman, good morning, Mrs. Williams. This is the day the Lord has made. And she responded with, oh, okay, I was wondering if you knew what to say. Okay, all right, okay. In Alabama, they know what to say, you know. Anyway, then she says to him, oh, you're my brother, aren't you? He says, yes. And then they start talking about their common Christian heritage, Christian faith. And then he starts asking her, how is she doing? And he tells her about the feet, tells her about the sleep, tells her about the other health problems. So the point is that he found commonality. He found a way to find common ground with this fellow human being who happens to be wrapped in a different skin color. But he was able to get beyond the fact that she was wrapped in a different skin color and see that, like everyone else, she's a complex individual who belongs to many different cultures. We all belong to many different cultures, not just the culture associated with our race or ethnicity or our nationality or our religion. And there's always a way that we can find common ground. And it's when you realize this, and when we figure out how to be creative enough to find that common ground, that's when we can get to patients, all patients, and we can find a way in that common humanity to provide care that is equitable. So I'm going to skip that. You guys know all about meaning for you, so I'm not going to spend time on that. You're living it. Okay, you've lived it. So cultural competency. This is the definition of cultural competency that I like to use, just the most commonly used definition. But ultimately, cultural competency is about finding common ground and interacting with people on the basis of that common humanity. And if we're going to deal with cultural competency merely by being race concordant That is finding enough healthcare providers to match race of patients and race of provider. I don't think we're going to get it done. Now, there's no doubt about it that patients, if given the choice, elect to have a healthcare provider of the same racial or ethnic background, disproportionately at least. So here, this is from a study that we did using data from the Commonwealth Fund. And what it shows is that in each case, each ethnic group, the patient was more likely to select a healthcare provider of their own racial or ethnic background. So white patients, white Americans are about 69% of the population, about 85% of them have a white physician. Black Americans are about 13% of the population, about 21% of them have a black physician. These are patients who had the ability to select, to choose their physician. Hispanics are about 13% of the population, about 19% of them have a Hispanic physician, and Asians are about 4% of the population. Nationally, about 52% of them have an Asian physician. So in every case, people select, if given the choice, they're more likely than not to select a physician of their same racial ethnic group. And we've done a couple of studies that shows that it actually does matter. Patients are more likely to report higher satisfaction if they have a provider of the same racial ethnic background, more likely to use preventive health services appropriately as well. So it does matter. But if that's the solution that we're going to rely on, it's going to be quite a while before we're able to do that, because the healthcare workforce simply is not diverse enough. This shows the diversity of U.S. physicians and also nurses, who are even less diverse than the physician the physicians. So how do we reach cultural competence? So when cultural competency first came out on the scene, this would be back in the late 1990s. I'm sure some of you remember the 90s, right? I was there, I remember. Early 2000s. You know, it came out mostly as essays and think pieces that people would write, admonitions to do better, not much in the way of specifics. And as a researcher, I found this very dissatisfying. And so I gave up on cultural competency for a while and said, you know, think pieces and essays, it's a great idea, but what does it really mean? How do you really get your arms around this? How do we know when we're culturally competent? What does that mean? So I left it for a while. Came back a few years later to look at that literature again and saw that it had not progressed much beyond think pieces and essays, admonitions to do good. And said, okay, well, what if I can come up with something a little more concrete? I'm a researcher, do some research. What if we can come up with a way of measuring cultural competency? And we developed this assessment tool called the COA 360. This is a measure of cultural competency for healthcare organizations, not for individuals, it's for organizations. And we use it in the CQI process, where you measure, you innovate interventions, you remeasure. In other words, the idea is to use cultural competency, treat cultural competency, treat health equity the way that we treat everything else in the healthcare industry. Everything we do is about metrics. We create metrics, we monitor progress, but when it comes to this issue of health equity, we don't treat it that way. We bring someone in for a training, or we have Mexican food day, right? I mean, you know, you've been to those, or we have ethnic clothing day where people come in and dressed in the ethnic garb, and that's the way we're dealing with cultural competency, right? Rather than using the same tools that we use in every other aspect of the healthcare industry. That is how we achieve health equity by design. The risks are great. I've talked a lot about those risks. These are documented. These are things that have been documented in the research literature as consequences of cultural incompetence, the consequences of it. There are cost implications, there are quality implications, there are patient outcomes and implications. But in the end, cultural competency is about opportunity. This changing demographics that we're facing creates great opportunity. And I want to close with a last story about one healthcare organization that I think has done an excellent job of working to achieve health equity by design, by incorporating it in a very serious way into the work that they do. And this was a hospital in Pennsylvania, and they were looking to hire a new chief of medicine. They did a national search, and they brought in a really strong candidate, a highly respected, highly regarded physician. They sent a security guard in uniform to pick her up at the airport and drive her back to the hospital. She went through a day of meetings with members of the C-suite, of the leaders within the hospital. And then when it was time to go back to the airport, the security guard in uniform drove her back to the airport. The first person the CEO wanted to talk to was the security guard in uniform and asked, well, what was she like in the car? Did she talk to you? Did she engage you? Was she friendly? How did she interact with you? And not entirely on the basis of that interview, but partially on the basis of that interview, she didn't get the job. And his attitude was, she's not going to fit in our organizational culture. Because in our organizational culture, we believe everyone is part of the care team. Who is the first employee that most patients engage when they come to our hospital? The parking attendant, right? And if that interaction sets that hospital visit down a negative path, that could impact that patient's experience, right? But when we do these cultural competency training programs, we focus on training the clinicians, who in most cases are the people who are least in need of it. They're spending the least amount of time, right? I said in most cases, not every case, by the way, for the record. So I would end by saying that the way to achieve health equity by design is to incorporate into the organizational culture of your organization a value for health equity, right? That's the start. We did one project where we identified, using hospital quality measures, we identified high-performing hospitals, safety net hospitals that have high-quality outcomes. Right? We went around to these 8 hospitals and we visited them, spent the day visiting with the leadership there, talking to people in the halls, just trying to get a sense of how is it possible that you have a 90% patient population that is either public payer or indigent, but you're able to have such a high-performing hospital. How can you do it? Everyone else says they couldn't possibly do it. To the point where even NQF now is adjusting, risk adjusting for socioeconomic status. Because the idea is that we can't provide quality care to poor people. So we went out and visit these hospitals to figure out what is it? Why are they able to do it? And this is what we found. That it was all about leadership. And it was literally top down. It was leadership. You had some hospitals that were led by males, some led by females, some led by physicians, some led by non-physicians, some led by people who had formal training in health administration, some that were not headed by people who had formal training, some with dynamic, charismatic leaders, some with leaders that were not dynamic and charismatic. None of those things mattered. What mattered was you had an executive who convinced everyone in that organization that they were going to be a high-performing hospital, period. It didn't matter what the background of the patients were. We were going to be a quality performer. So I leave you with this. The way to achieve health equity is to have leadership that values it, that genuinely values it, or at least is able to fake being genuinely, that was a joke, genuinely values it, and is able to get that value to permeate throughout the organization and get people to realize that there was one hospital, I do want to tell you this one quick story. There was one hospital that did this. New CEO comes in, and she changes everyone's job description to say, to ensure good quality care to all patients and be the parking attendant. To ensure good quality care to all patients and work in the cafeteria. To ensure good quality care to all patients and whatever the other responsibility was. So now everyone's job is to ensure good quality care to all patients And you are evaluated in part on the extent to which you do that. So that there's a patient walking around lost in a parking lot garage, it is your job. It's not just the right thing to do, it is your job. You are paid to see that that patient gets where they need to be. This is how we bring about health equity by design. We do it by putting it into the design of our organizations and making it a core value of the organizations that we lead. So I'll stop there, and I'm looking forward to talking to you guys and having a dialogue.